Hello. We're headed off now on Lecture 4 in Childhood Psychopathology. Today we're going to talk about assessment and diagnosis of mental disorders in a more general sense. As we get into each specific disorder, we'll talk more about the diagnostic categories within the DSM and the ICD-10. But I want to introduce a little bit about how we assess and go about diagnosing mental disorders. So let's start with sort of a definition and assessment of diagnosis. Assessment involves the systematic collection of relevant information. So we're going to assess an individual from a variety of viewpoints. So this will include information about a child's strengths and accomplishments. So this is probably going to include information from their school, their teachers, talk with their parents. So I'm going to know what they're doing well, not just what's going wrong, because that's going to help us really get an idea of what's going on. We want to do a thorough assessment both for diagnosis and for treatment. And so understanding the child in much more detail is certainly going to allow us to come up with a better treatment plan. And so I know some of the things you might want a child to do or not something a child might not want to do. For a child that's not interested in sports, suggesting that they join a soccer team. This is an example I'm pulling out of my past. I guess would be the best way to talk about that. Probably not going to be useful for that child if that's not something they're interested in. So really don't want to think about what's going to work well for that child. So also, kind of from now on, oftentimes I'll shorthand diagnosis and treatment with DX and RX. Just out of simple shorthand. This is how we shorthand those two particular terms. So we'll be doing that. So as I said, assessment's going to include information from home, school, as well as direct assessment of the child. Chat with them, watch them, kind of oftentimes watching them play games, that sort of thing will be an important part of that kind of assessment. We're also probably going to try to include some objective assessment tools. And I use that in quotes because objective is in the eye of the beholder. Certainly more objective than some of the other subjective assessments we might use. But the American Psychiatric Association, along with the DSM, has actually come up with this fairly complete and interesting set of symptom measurements that you can then use. I've only included the first page, and if you're looking at this on your phone, you probably can't see it at all. But this is a DSM-V parent-guardian rated level 1 cross-cutting symptom measure for children aged 6 to 17. And they're things like, complained of stomach aches, headaches, or other aches and pains, slept less than usual for him and her, but still had lots of energy, started a lot more projects than usual or did more risky things than usual. And then the parent's going to assess this. What's interesting about this is this then routes you from this sort of level 1 to level 2. So once you finish this, once the clinician would get this back, they might look at it and then have the parent do a level 2 diagnosis tool. So I think this is a level 2 diagnosis tool, and this is one that would be given to the child themselves, which is obviously a little bit shorter for a child, and the language is a little bit different. At least theoretically it should be. Like the language and the instructions for this are ridiculous for a child aged 8. But you're going to ask them, and oftentimes the clinician, I think, would ask them, in the past week, how often could you not stop feeling sad? Never, almost never, sometimes, often, almost always. And so this is a depression assessment for a child aged 11 to 17. And this is going to help us try to diagnose whether or not an individual child might have depression. In an adult, we might use the Beck Depression Inventory or the Profile of Mood States to help us assess their mood and their depression. This is actually going to really help us route through some of the diagnostic criteria for an individual. So for diagnosis, any diagnosis is made according to criteria that are laid out in the DSM-V and the ICD-10. One of the things that's important to understand about this, and one of the reasons why I will be teaching about this in more generalities, is that by the time any of my students end up diagnosing anyone as actual clinicians, all of this will have changed. So understanding how this works and the issues surrounding diagnosis is really far more important to me. Now, when we get into the disorders, yes, you'll have to know what the criteria are for depression, mostly because that's what tells us a lot about what depression really is. So a lot of times we have to think about making a differential diagnosis. So these are decisions that are made about mutually exclusive categories of a disorder. So we have to kind of try to differentiate between, let's say, a depression and a bipolar disorder. And in fact, some of the questions in that parent, let me back up here so that I can show you. If we go to this parents, guardian, cross-bond cutting symptom measure, started a lot more projects than usual or did more risky things than usual. This is trying to get at bipolar disorder, whereas seems sad or depressed for several hours is getting at depression, so that can get at depression or bipolar disorder. The differential diagnosis might come from something like this, started more projects than usual, which would be indicative of mania. So that differential diagnosis is going to become very important. So overall, researchers and clinicians are concerned with diagnostic efficiency. Basically, we want to maximize diagnostic hits and minimize diagnostic misses. Again, take a look at the lecture I have posted on YouTube about testing. It's about hits, misses, false alarms, and correct rejections. So basically the idea is the diagnostic tool is either going to say, yes, this person has a disorder, or no, they don't. And the person's either going to have a disorder or they don't. And so there are sort of 4 different ways this might come out. So we want to certainly minimize misses. We want to maximize hits, but also we want to minimize false positives. We don't want to diagnose something with a disorder they don't have, treat them with a disorder they don't have. Again, we want to make sure that we minimize those misses. So we don't just want to maximize hits. We also want to minimize misses and minimize diagnose individuals with a disorder they don't have. And that becomes really important. So when we're trying to do differential diagnosis between schizophrenia and bipolar disorder, because those medications are very different, and depression and bipolar disorder, because some medications for treating depression will trigger manic disorder. This is all very difficult. There's a reason why we have clinicians go through a great deal of training in order to do this. So I think it's very important. So how do we go about this assessment? Well, interviews, clearly an important part of this. A lot of people to interview, different perspectives and agendas, and that's important to keep in mind, particularly when we're dealing with children. One parent might have an agenda over the other, and this becomes very important when we're talking about assessing children in the process of a divorce. So you have to watch out for what one parent might say versus another. So we want to look at the areas of agreement as well as areas of disagreement. So everyone seems to agree the child has this particular functioning, and so that seems to be important. But areas of disagreement, is this an agenda, or is this person not seeing it? Are they not around? You have to really think about these things and do what we call reversing the gaze. Like, what is that person coming from? What is their thinking? Why are they saying this? What may be behind what they're saying? Do they not see it? Or are they seeing something that's not there? Really important things to consider. None of this is easy. So the format of child interviews will range from sort of structured play to highly planned sets of questions to open-ended conversations. We'll take into account characteristics, of course, age, whether the child is comfortable interacting with a clinician apart from parents or apart from one parent, not the other. That's going to be an important diagnostic tool. There's going to be a number of these different kinds of structured assessments. We already saw kind of the checklist kind of things, but we also might do something like the thematic apperception test, where they're given individual cards where they're asked to tell a story about what's happening in the picture. The house person tree test is another projective test that might be used, where the child is asked to draw a house, a person, a tree, and then asked about the elements within that. So lots of different ways we might do this as part of that interview. Now, the number of standardized tests, these can be objective and subjective, but they all should have a standardized way in which they are conducted. So there's assessment in which data can be compared to sort of large samples, including normally developed children and children with a variety of diagnoses. And in general, the most standardized are the objective tests, because it's very easy to say, most children answered A, whereas, children with this disorder answered B. Oversimplifying, of course. Whereas some of the projective tests I just talked about, you can see kind of patterns of responses for kids with some types of disorders. So I think that's really important. Some of these might include intelligence tests. These will include the Wechsler Intelligence Scale for Children, which is the WISC, or the Stanford-Binet, which I think is used a lot less. The WISC is really the gold standard for intelligence tests for children. Has to be conducted by a licensed clinical psychologist, somebody who is trained specifically in using that particular intelligence test. Very important. Personality tests can include both objective and projective measures. Personality is really tough to assess in children because it's sort of still forming. It's kind of like trying to decide what a cake's going to taste like. Well, it's still in the oven, because the best way to think about that. Objective measures are going to include things like the NEO, which stands for neuroticism, extroversion, and openness to experience. Projective measures will include things like the thematic apperception test, the house person tree test, or the Rorschach. The Rorschach is certainly used, whether it should be or not. Other quote-unquote objective tests that are often used that shouldn't be include the Myers-Briggs, so the MBTI, the Myers-Briggs type inventory. Very bad reliability and very bad validity. So you want to look into that. And certainly those of you who go on to clinical work are going to have to take a measurement and testing class, and that's going to be really important. Other diagnostic tools. I'm not sure I'll be able to show you. Actually, no, you won't. Never mind. There is this really great mental health screening chart for primary care doctors. And so you can go to this link, which is obviously long, or you can just Google mental health screening primary care doctors and take a look at it. But it's this really great, pretty thorough screening chart that's a useful diagnostic tool for primary care doctors. And I think it's really important for you to take a look at those. Physiological measures. Those of you in my class, your textbook likes to ignore these. These are increasing in importance. And I think I have really come a long way in terms of differential diagnosis, so they can be used to eliminate potential physiological causes, I think is one of the first things to think about. So some good examples are if a child is depressed, lethargic. I think a really important part of this is going to be doing a thyroid screening, because individuals with low thyroid can have very low energy or depression. We can use structural MRI scans to eliminate potential brain injury as a potential source of mental problem or disorder. We can now use PET scans to differentially diagnose Alzheimer's disease from vascular dementia, although it's not generally done because there's really no reason to. One of the important things to understand about any diagnostic tool is it's only helpful insofar as that it helps us treat the patient. And if it doesn't help us treat the patient, it's not worth doing. But thyroid screening, certainly going to be an important tool in our lineup for things like lethargy, depression. We might want to send somebody for an EEG. If they're having a seizure disorder, we might send them for a sleep study to see where their sleep is disrupted. They might have sleep apnea. It might be why they're having attention difficulties. So there are lots of physiological measures that I think we want to think about as important diagnostic tools. Observation. Clinicians usually observe children in clinical settings, such as offices, but they may want to go out into natural settings, home, school, playgrounds, important areas. I want to spend a few minutes talking about the Individuals with Disabilities Education Improvement Act, because this has different diagnostic categories and certainly something, if you're a school psychologist, that you're going to be interacting with a lot. But I also want to point out some issues with how it's crafted and why it's a problem. So, those of you who aren't familiar with me, I've actually been to law school. I didn't get my law degree. I've done a year and a half. I just was bored. This comes from the United States Code, so this would be cited as 20 U.S.C. 30, which means Section 20, Chapter 30, Section 1401. So the term child with a disability means a child with intellectual disabilities, hearing impairments, speech or language impairments, visual impairments, serious emotional disturbance, orthopedic impairments, autism, traumatic brain injury, or other health impairments or specific learning disabilities, and who, by reason thereof, need special education and related services. So basically, this is how we want to make sure that any individual who has difficulty can get educated in an appropriate way. So that's disability. This obviously includes both mental disorders and physical disabilities. Learning disability. This is one of those cases where the more you know, the worse off you might be. So the term specific learning disability means a disorder in one or more of the basic psychological processes involved in understanding or in using language, spoken or written, which disorder may manifest itself in the imperfect ability to listen, think, speak, read, write, spell, or do mathematical calculations. Really, they're talking about things like, as it says down here, dyslexia, perceptual abilities, traumatic brain injury from concussion, developmental aphasia, other developmental difficulties. I suppose somebody with developmental prosopagnosia, which is an inability to recognize faces, would fall in here somewhere. Acalculia would certainly fall in that, which is an inability to do math. What I want to point out, and this is what I find offensive, and this is what happens when you let politicians write diagnosis categories. This term does not include a learning problem that is primarily a result of visual, hearing, or motor disabilities, or intellectual disabilities, or emotional disturbance, or of environmental, cultural, or economic disadvantage, which is basically Congress's way of saying, I'm sorry that you weren't able to learn how to learn because your parents were struggling through poverty and working 3 jobs. Suck it. So I'm a little irate about this particular passage. As we're going to learn in this course, poverty is directly related to developmental disability and learning disabilities, and this is infuriating. Anyway, I will finish that rant later on. That gets us then into how we evaluate under this law, and this I thought was really interesting. Fits right in with what we've been talking about. Here's how you are required to evaluate underneath this particular statute, and this is in section 1414. So first of all, you have to use a variety of assessment tools and strategies to gather relevant functional, developmental, and academic information, including information provided by the parent that may assist in determining whether the child is a child with a disability, and the content of the child's individualized education program, including information related to blah, blah, blah. So one of the things this does is it sets up, you have to have a specific treatment plan for each individual child that falls underneath this particular statute. Importantly, you are not to use any single measure or assessment as the sole criterion for determining whether a child is a child with a disability or determining an appropriate educational program for the child. And I think that's really important. No single point assessment just because they failed an exam or because this kind of information came from one person. We have to use multiple assessments. And technically sound instruments is the other part of this. And so we want to use the WISC. We want to use very clearly structured, highly valid and reliable measures. And so I think that's particularly important. Some final thoughts on this. Diagnosis is always a best estimation or guess, as we might say. And that's kind of a problem because we're relying on information from a variety of people. We're relying on people's memories. The more objective you can be about a diagnosis, the better. And so I think that's really important. But finally, policymakers and people with no expertise often meddle in diagnostic categories, and often for political reasons. And so when we start thinking about diagnosis, you have to be really mindful of where the diagnostic categories come from and what the politics behind those might be. So keep that in mind. All right, with that in mind, in our next lecture, we're going to get into some discussion of treatment options.